Hello, everybody. Today we will be starting our antibiotics chapter. The first one is the introduction to antibiotics, antimicrobial therapy. So, antimicrobial therapy means we are trying to kill or stop the growth of microorganisms, bacteria. Okay, and how can we select an antimicrobial agent? We can identify the infecting organism through microbial cultures and everything. But when a patient is presented to the hospital, the first thing what we are doing is we have to find who is, we have to decide what drug we have to give at the moment because the patient is in the hospital with an infection. We cannot wait for the blood cultures to come, which is going to be sometimes 24 hours or whatsoever. We cannot wait, right? So we will start with an empirical antimicrobial therapy. Empirical antimicrobial therapy means it is a broad spectrum antibiotic. It will be given to the patient. Broad spectrum means they will be having activity towards a wide range of microorganisms. That means bacteria. Narrow therapeutic or narrow spectrum antibiotics means antibiotics which are effective or sensitive to a very tiny number of, sometimes just one bacteria they might be sensitive to, or they will be having activity against only one bacteria. Whereas broad spectrum means they have activity against wide variety. So it helps, really helps, right? When an infection is not identified or infecting agent is not identified, a broad spectrum antibiotic is really helpful. So we will give this medication at the beginning. And right after the culture and sensitivity report, we can substitute it with a narrow spectrum antibiotic. Usually, commonly, third or fourth generation cephalosporins, doxycyclines, fluoroquinolones, they are all given as broad spectrum antibiotics. And then the third one is based on antimicrobial susceptibility, whether it is bacteriostatic or cidal. From the name itself, you can see that bacteriostatic means it is causing stasis or arresting the growth and replication of bacteria. For example, chloramphenicol, erythromycin, clindamycin, sulfonamides, tetracyclines. These drugs will stop the growth or replication of the bacteria. Whereas cidal means they are killing the bacteria. Aminoglycosides, beta-lactams, vancomycin, quinolones, rifampicin, and metronidazole. These drugs, they can destroy the bacteria or kill the bacteria. What is the effect on site of action of an antibiotic? Blood-brain barrier effect. You know, the blood-brain barrier is going to protect our brain from harmful substances. So they will limit the entry of antibiotics into the CNS. Only free means not protein bound or not bound for tissue proteins or plasma proteins. Lipid soluble, only lipid soluble drug can cross the blood-brain barrier. And low molecular weight drugs, they can cross easily. Whereas high protein bound drugs or high molecular weight drugs, they can show a poor CSF penetration, cerebrospinal fluid penetration. So what will happen if the drug is not having a appropriate penetration or a reduced penetration? They may lead to treatment failure, especially in infections which is occurring in our brain or central nervous system. So why is it important? Why the blood-brain barrier effect is important? So it is important in meningitis and other brain infections. Okay. So meningitis means it is the inflammation of the meninges, right? So when there is inflammation, it can increase the blood-brain barrier permeability. It can increase blood-brain barrier permeability. So the drugs, antibiotics, will cross better during meningitis. Some examples of drugs with a better CSF penetration, as you know, vancomycin, which is a drug of choice for meningitis, ceftriaxone, cefotaxime, meropenem, vancomycin, all these drugs. These are some of the examples of drugs with better CSF penetration. You will study which class of drug is this, what is the mechanism of action in the coming slides, in the coming chapters. But this is just keep it in mind that they have better CSF penetration. Key concept, blood-brain barrier, they act as a protective filter for the brain. Of course, yes, they protects brain from, for example, hepatic encephalopathy, brain encephalopathy. The blood-brain barrier is protecting the brain from, and it is not allowing ammonia to cross, right? Now, molecular weight. As I said, low molecular weight drug has enhanced ability to cross the blood-brain barrier, whereas compounds with a high molecular weight, they penetrate poorly. For example, vancomycin can easily go through. Next is about the protein synthesis. Okay. A high degree of protein binding will restrict the entry into the CSF. Pretty straightforward. If the antibiotic has high degree of protein binding either in the plasma or in the tissue, less free drug is available. As I always say, only a free drug contributes to pharmacological effect. So when the antibiotic is highly bound to the plasma protein, less drug is going to enter the cerebrospinal fluid. Okay. Hence, reduced penetration into the brain, CSF, and the central nervous system. So we won't get an action, isn't it? So for infections like meningitis, brain abscess, CNS infections, doctors usually prefer antibiotics that can cross the blood-brain barrier and reach adequate CSF concentration and drugs with a high protein binding are ceftriaxone, warfarin. These are very, very highly protein bound. Okay, but ceftriaxone can cross the CSF during meningitis because the meninges is inflamed. Due to inflammation, it opens the blood-brain barrier and they can cross. Okay, but usually in brain infections or CNS infections, it is better to choose a drug which can cross the blood-brain barrier easily and a drug with less protein binding. Okay. Same is in the case of most of the drugs. If the protein binding is very, very high, the amount of drug reaching the site of action is less, of course. It's not in the case of brain, but also in case of all other drugs. Susceptibility to transporters or efflux pumps. Okay. So, there are some efflux pumps.
Ma'am, or doubt
Yes, yeah.
Ma'am, protein bound ആയിട്ടുള്ള ഡ്രഗ്സ് ഹൈലി പ്രോട്ടീൻ ബൗണ്ട് ആയിട്ടുള്ള ഡ്രഗ്സ് ആകുമ്പോഴത്തേക്കും ആ ഡ്രഗ്സിന് ലോങ്ങർ ഡ്യൂറേഷൻ ഓഫ് ആക്ഷൻ ഉണ്ടാവില്ലേ? സ്ലോലി ഡിസോസിയേറ്റ് ചെയ്ത് അങ്ങനെ ഒരുപാട് നേരം ബ്ലഡ് നിൽക്കത്തില്ലേ ഡ്രഗ്?
That's right. Yes. A highly protein bound drug has a a longer duration of action because it stays in the blood for a longer period of time. Their half-life will be high and the duration of action will also be high. But if they
അപ്പൊ
sorry,
സോറി.
yeah, but if they has a low protein binding, the volume of distribution will be high. Volume of distribution is dependent on different factors, but one of the factors is this: if the drug has decreased protein binding, they will easily participate in pharmacological action by reaching the site of action, and they have a wide range of distribution.
ഓക്കെ
Is that okay?
ഓക്കെ. അപ്പൊ ടോക്സിസിറ്റി കൂടത്തില്ലേ ഇങ്ങനെ ഡ്യൂറേഷൻ കൂടുമ്പോ?
Toxicity depends upon different factors. So when we are giving a highly protein bound drug, we know that the drug is going to stay in the blood for a long period of time. So in order for the drug to participate in the pharmacological action, we will consider the dose of a drug such that those needed to be bound to plasma protein, they will go there, and the rest of them go to the pharmacological action. And also the toxicity will occur in cases like displacement reaction. That means I always explain like
Yes.
When another drug
Enzymes.
having a stronger protein binding is coming and displacing the drug from the protein binding site, they are available as free drug and can cause toxicity. Otherwise, when they are bound to protein, plasma protein, they are not taking place in pharmacological action. They slowly dissociate and gets eliminated from the body. That is not going to cause toxicity.
Okay.
Okay. Clear for you?
Yes, ma'am.
Perfect. So now we'll talk about efflux pumps and transporters. There are several transporters, like we know about the glucose transporter, right? They transport glucose. So just like that, some antibiotics will be having affinity for bacterial transporters. Otherwise, efflux pumps. They can remove the antibiotics from bacterial cells. Right. So when the antibiotic is removed from the bacterial cell, the intracellular drug concentration is going to be less. And there will be very less antibiotic which is going to cause an effect or kill the bacteria or stop the growth of bacteria. So this can contribute to antibiotic resistance, which may cause multi-drug resistance. This is one of many causes of drug resistance. So one of the cause is this efflux pumps, action of efflux pump. The efflux pump is removing antibiotic from the bacterial cell, so there is less amount of antibiotic for giving an effect, hence causing resistance. So antibiotics that are commonly affected include tetracyclines, macrolides, fluoroquinolones because of the action of efflux pumps. Okay, I'm sorry. So the key concept is that bacteria can pump the antibiotic out of their uh, cell before it can work. So even if we give an antibiotic, there is no effect. Okay. Now, what is minimum inhibitory concentration and minimum bactericidal concentration? Very, very important. So minimum inhibitory concentration means it is the lowest concentration of an antibiotic which can stop a visible bacterial growth in a 24-hour incubation. That means you might have done during your pharmacy course, you might have done petri dishes and you will put some sort of any kind of some nail debriments or soil or whatsoever, and then you put antibiotic in the
Zone
in
of
the, in
inhibition.
the center. Yes, zone of inhibition. Very good. So you put antibiotic in there and you can see at the lowest, which is the lowest concentration of antibiotic, which can stop bacterial growth around them. That means if the antibiotic is sensitive, if this is the point where you gave the antibiotic, there will be some area around it, so where antibiotics can affect and stop bacterial growth. It can tell you how sensitive a bacteria is to an antibiotic. Next is minimum bactericidal concentration. Cidal, killing. So it is the lowest concentration of an antibiotic that can kill a bacteria after 24 hours incubation. So what is a feature of MIC and MBC is that MIC, they can stop bacterial growth, whereas MBC, it depends upon killing bacteria, the minimum concentration or lowest concentration which can kill the bacteria. MIC is talking about bacteriostatic effect, and the drug required, the drug level, the concentration required will be the lowest because we are inhibiting. And this can help to choose an antibiotic sensitivity. Minimum inhibitory concentration is used to um, identify the sensitivity of an antibiotic to a particular bacteria. Whereas minimum bactericidal concentration is talking about bactericidal effect. Usually we need a high level of drug for the action, and also it helps to know what is the killing ability or how far is the extent of killing for a particular bacteria, particular antibiotic. Now, effect of the site of infection. So the effect of an antibiotics basically depends on whether the drug is going to reach the infection site. Very important, right? So some tissues that are very difficult for antibiotics to penetrate, for example, as we talk about blood-brain barrier in bone, in certain kind of abscesses, in the prostate, if there is an infection in the prostate, it is really difficult for the antibiotic to cross that area and reach the infection site. So even if the bacteria is very effective in the lab and it showed some sensitivity, if the patient or if it involves an if a site of infection where the penetration is very less, the treatment may fail because the drug is not able to reach the particular site of infection or in an adequate concentration at the site. Why is it? Because there can be poor blood flow to these sites. We have certain areas in the body which is highly vascularized. There will be like kidney, liver, those areas. Brain is highly vascularized, but still, due to the blood-brain barrier, it is not having this property. So, abscess, it is a collection of pus. So, pus and dead tissue can reduce the antibiotic penetration. And although there will be an acidic environment inside the abscess, this can also decrease the drug activity. So in that case, what we can do, we have to do drainage. In addition to antibiotics, the pus drainage can be done. In the prostate gland, usually most of the antibiotics find it difficult to penetrate because of the lipid membrane barrier and also the prostatic fluid pH. So only certain antibiotics work well in prostatitis, for example, fluoroquinolones, trimethoprim sulfamethoxazole. So only few drugs they reach the prostate tissue and penetrate the tissue to give antibiotic action. Next, so a low minimum inhibitory concentration means the organism is more sensitive to the antibiotic, whereas high MIC, this is something which you have to understand from this definition. You might be thinking, why should I study this? This is the point where you have to study it. That means low MIC, it is more sensitive. The organism is more sensitive to the antibiotic. High MIC means we need a high concentration and the organism is less sensitive or it may be resistant. So MBC is commonly higher than MIC because killing the bacteria always require more drug than just stopping the growth. We already discussed this. Right. We need to have more concentration in order to kill the bacteria. So MIC stops the growth, MBC kills the bacteria. And for severe infections such as endocarditis, meningitis, sepsis is a multi-organ infection, right? So in these
Yes.
conditions, we usually prefer a bactericidal drug because it is very important to completely kill the microorganism in these situations which are very severe. A simple example include if the MIC of a drug is 2 mcg per ml and MBC of a drug is 8 mcg per ml, that means the 2 mcg can stop the growth of the bacteria, whereas 8 mcg can kill the bacteria completely. I hope that's clear to you, right?
Yes, ma'am.
Perfect. So, determinants of rational dosing. We are going to discuss about few important things. First one is concentration dependent killing. So, this is type of approach of the antibiotics. The first one is concentration dependent killing. So, in concentration dependent killing, the bacterial killing increases as the drug concentration increases. Okay. Um, just one moment. So, concentration dependent killing means it is based on the drug concentration. I mean, the killing of the bacteria is based on the concentration of the drug. As the concentration of the drug increases, there will be faster and greater bacterial death. Higher the antibiotic concentration, the faster and greater is the bacterial death. So, what is the goal? Achieve a high peak concentration, Cmax, maximum concentration, compared to the minimum inhibitory concentration. Important points. So the effect depends on peak concentration, Cmax, maximum concentration, and is to MIC ratio. Often has a post-antibiotic effect. That means concentration dependent killing drugs has post-antibiotic effect. PEE means even if we stop the drug or even if the drug level falls lower than the therapeutic range, the bacterial the killing action will continue, or the bacteria continue to be suppressed even after the drug level falls from the therapeutic range. That is known as post-antibiotic effect, and after some time this goes away. So usually these are given at large doses and less frequent intervals. Drugs which have concentration dependent killing include aminoglycosides, gentamicin, amikacin, fluoroquinolones, ciprofloxacin, levofloxacin, daptomycin, and metronidazole. So time dependent killing. We have concentration dependent killing and time dependent killing. So what is time dependent? It depends on here the killing of the bacteria is dependent on how long the drug concentration stays above minimum inhibitory concentration. So we have a minimum inhibitory concentration where the bacteria can be, the minimum concentration there where the bacteria can be killed. And it doesn't depend on the concentration, rather it depends on how long, the time in which the drug concentration stays above the minimum inhibitory concentration. So here, even if we are increasing the concentration above the MIC, we will not be having much of an effect because it depends upon the time, the duration. And the main factor, time above minimum inhibitory concentration, and we need frequent dosing here because we need to maintain the therapeutic range above minimum inhibitory concentration. And or otherwise, even sometimes frequent dosing can be given, or otherwise we have to maintain a continuous prolonged infusion in some cases. Here we didn't have to give frequent intervals, but we needed to give larger doses. But here we need to give frequent doses, continuous prolonged infusion, and smaller doses can be given. For example, beta-lactams like penicillin, cephalosporins, carbapenems, macrolides, clindamycin. Yeah. Next is post-antibiotic effect. We already discussed about that, right? Because the persistent suppression of bacterial growth even after we stop the medication. Why is it important? Because this can allow longer dosing intervals, continued bacterial suppression, and these can be seen in aminoglycosides and fluoroquinolones. Chemotherapeutic spectrum. We already discussed what is broad spectrum and narrow spectrum. Narrow spectrum means the agents which are effective only on a single or a very limited group of microorganisms. For example, isoniazid is active against Mycobacterium tuberculosis. Extended spectrum means a little bit more extended. The spectrum is a little bit more extended. That means modified to be effective against gram-positive and also against some gram-negative bacteria like ampicillin. Whereas broad spectrum, they have a broad spectrum. That means they are active against a wide variety of microbial species like fluoroquinolones, carbapenems. So these broad spectrum antibiotics has a problem. Even though they are helpful, they have a problem. They can drastically alter the nature of normal bacterial flora and they can precipitate something called superinfection. So broad spectrum means they are effective against wide range of organisms. Also, they can also kill harmful bacteria in the body as well as our normal protective flora. So, superinfection occurs when normal protective bacteria in our body, like especially in the gut bacteria, they are destroyed by antibiotics. So, resistant organisms that are not affected by the antibiotic will begin to overgrow. Understand? So, we have a normal protective bacteria which is to prevent our gut from some infections. So here what is happening? Those organisms will begin to overgrow. There are different causes. First one is most important, broad spectrum antibiotic is given because they can kill harmful bacteria and as well as normal protective flora. And we have this normal flora, especially in gut, mouth, skin, vagina. So these organisms will be reduced. So what will happen? Some organisms which are already naturally resistant to antibiotic which is present in this normal flora can die. Okay, they becomes natural. Some organisms were naturally resistant and they can multiply rapidly. Overgrowth occurs and these resistant microorganisms dominate in number and effect and they can create a new infection. That is known as superinfection. Why broad spectrum antibiotics are causing this superinfection? It is because they affect a wide range of bacteria. Normal flora is also destroyed so that the resistant organism, naturally resistant organisms present in the body overgrows. And more common causative organism antibiotics include clindamycin, cephalosporins, fluoroquinolones, and broad spectrum penicillins. So there are some examples of this superinfection. The first one is Candida overgrowth. How is it going to happen? Normal bacterial flora keep Candida under control in the mouth. Antibiotics can destroy this bacteria and Candida fungi will overgrow. So oral candidiasis can occur. Oral candidiasis is known as oral thrush. Then vaginal candidiasis, vaginal thrush. So there can be white patches in the mouth. In case of vaginal candidiasis, we have itching, thick white discharge. They can occur. This is the first infection, Candida overgrowth. Second one, Clostridium difficile. So Clostridiosis difficile colitis. It is known as pseudomembranous colitis as well. Pseudomembranous colitis. It is caused because of Clostridium difficile bacteria. So the normal intestinal flora, they can suppress this Clostridium difficile. But when we are giving broad spectrum antibiotics, they can destroy the gut bacteria, normal gut bacteria. So what is happening? Clostridium difficile can survive and multiply. Okay. So what is it doing? The Clostridium difficile, they can produce toxins, toxin A and B. What is this toxin gonna do? They can cause inflammation of the colon, mucosal damage, and pseudomembrane formation. That's why it is known as pseudomembranous colitis. It is very, very important. Very commonly asked question. So symptoms of Clostridium difficile colitis, severe diarrhea, fever, abdominal pain, foul-smelling stool, pseudomembranous colitis. Then high-risk antibiotics, clindamycin, cephalosporin, fluoroquinolones, ampicillin, and amoxicillin. So how can we prevent that? Avoid unnecessary antibiotic use. Use it only when it is indicated. Never prescribe antibiotics for all infections. And then use a narrow spectrum antibiotic whenever it is possible. Obtain a bacterial culture sensitivity test whenever it can be done. Maintain an infection control. Rational use or antibiotic microbial stewardship is very important. And probiotics may help in some patients. It is very important because probiotics can protect the gut flora. Do not take it along with the antibiotic. Take it at a different time. and you can protect your microbial flora. Then we will go back where we were. We were here. So we were talking about the broad spectrum antibiotics, right? Next, prophylactic use of antibiotics. Antibiotics are not only used for infections, rather they can be used for prophylaxis. We can pre-treat to prevent streptococcal infections in patients with a history of rheumatic heart diseases. Then also during dental extractions or any uh, dental procedures for patients with an artificial heart valve. Also in patients who are undergoing dental procedures, they receive prophylactic antibiotics like ampicillin and amoxicillin. And also, treatment prior to most procedure can decrease the incidence of infection afterwards. Effective prophylaxis is directed against the most likely organism. For example, patients who are admitted in the hospital to prevent nociceptive infections, like infections that can spread in the hospital-acquired pneumonia. In those cases, we can give prophylactic antibiotics in patients who are undergoing surgery or who is in the ICU in the hospital for a long period of time. So, in these patients, we can initiate antibiotics to prevent the incidence of an infection. Also, you might have heard, like most commonly, in patients who are traveling to countries like Africa, where there is a high probability of having malaria, travelers' diarrhea, they will take prophylactic medications. For travelers' diarrhea, doxycycline can be given. They take the medication for a long period of time. To prevent malaria, they take atovaquone which we will study in the coming chapters. Don't worry about it. So they will take these medications. Right. Um, you might have seen people take Ducoral to prevent travelers' diarrhea, typhoid, isn't it? Right. No complications.
സർജറിക്ക് പ്രയറായിട്ടും കൊടുക്കത്തില്ലേ?
Yeah, that's what I was saying. In the hospital, when they are undergoing a surgery or they are admitted in the hospital in the ICU for a long period of time, they will be given this to prevent hospital-acquired diseases, infections. That's right. Hypersensitivity reactions, one of the complication of antibiotic therapy, because there can be some allergic reactions which are immune mediated because of this antibiotics, because the antibiotics are acting on antigens or haptens. Okay, so usually, for example, penicillin, they can cause some sort of uh, hypersensitivity reactions. The penicillin is going to bind to a protein in the body and they form a hapten protein complex. So this haptens means they are some small molecules. They do not trigger an immune response by themselves. They do not have immunogenic activity by themselves. But when they are attached to a larger protein or antibiotics, see some antibiotics, they can become immunogenic. So some antibiotics, they act as haptens. They bind to the body proteins and they form a antigen complex, like a hapten protein complex. So the immune system of the body will recognize this as a foreign body. Whenever there is a foreign body in our in the body, immune system fight against it. So they will produce antibodies. Here we can see an allergic or hypersensitivity reaction. So IgE antibodies will be formed. So re-exposure can cause mast cell degranulation and histamine release. This is taking part in allergic reaction. So in that case, patient may develop rashes, urticaria, angioedema. Urticaria means hives. Okay. Angioedema, anaphylaxis, fever, all these can occur. Okay. So hapten, it is an incomplete antigen when it binds with the body protein. It needs a carrier protein to stimulate the immunity. When they come together, they can the body identify it as a foreign body and cause an antigen antibody reaction. So the key mediator is histamine. Direct toxicity, that means toxic effect caused directly by the drug on the organs or the tissues. This is basically, the direct toxicity is basically dose dependent. So high doses might cause this reaction, and if you are trying to reduce the dose, sometimes this reaction can subside, but usually we stop the medication, we stop changing the medication and prevent challenging, because these kind of direct toxicities can be very serious. For example, we will study some direct toxicities now itself. Even though we are going to study in particular class, but we will study most important things here such that you don't forget it. First one, vancomycin-induced red man syndrome. How is it caused? So when we are giving vancomycin as a rapid infusion, this can cause some direct histamine to release from the mast cells. This is not an allergic reaction, rather it is a toxicity. So it can result in red flushing of face or neck. That's why it is known as red man syndrome. Itching, hypotension. So how can we prevent this? We can do not give it as a rapid IV infusion, give it as a slow IV infusion, and you also can give antihistamines. Next is aminoglycosides. Aminoglycosides can cause two different toxicities, ototoxicity and nephrotoxicity as well. So oto means something is related to the ears. So the drug can accumulate in the inner ear fluid, and it can damage the hair cells of cochlea and vestibular apparatus, which can result in tinnitus, vertigo, even hearing loss. And next one is nephrotoxicity, because the drug can accumulate in the renal tubular cells, causing damage to the renal tubular cell, which can result in acute kidney injury and elevated creatinine, which can lead to kidney failure if untreated.
Ma'am, ഒരു ഡൗട്ട് ചോദിച്ചോട്ടെ?
Yes,
അമിനോഗ്ലൈക്കോസൈഡ്സ് ഓട്ടോടോക്സിസിറ്റി ഉണ്ടാക്കുന്നത് ഡോസ് ഡിപ്പെൻഡ് ആണോ?
it is also dose dependent. Yeah.
Okay.
Next is chloramphenicol induced gray baby syndrome is also there, and bone marrow suppression is there. It is because of they can inhibit mitochondrial protein synthesis in human bone marrow cells and result in pancytopenia and aplastic anemia. Pancytopenia means all blood cells will be deficient, like not just anemia. Anemia means the hemoglobin will be decreased, RBCs are the problem. Leukopenia means leukocytes are reduced. Neutropenia, neutrophils are reduced. But pancytopenia, all blood cells will be deficient. Aplastic anemia sometimes can be irreversible, so it is very important. Fluoroquinolones can cause tendon and cartilage damage. Why? Because they can damage the connective tissue in the cartilage and tendons because of oxidative stress, causing tendinitis, inflammation of the tendon rupture, cartilage damage. Who are the high-risk groups? Elderly, steroid users, athletes. Okay. Next is tetracyclines. Tetracyclines are going to affect bone and teeth because they both have calcium. They chelate the calcium and deposit in growing bones and teeth. Okay. The chelated calcium can result in tooth discoloration, enamel hypoplasia, impaired bone growth. So they should be avoided in pregnancy and also in children under 8 years because they can affect the development of bones and teeth. Next is sulfonamides induce crystalluria. They sulfonamide precipitate in acidic urine and form crystals. So what will happen? Kidney stones, first of all, then hematuria, RBCs in urine or blood in urine, Renal irritation. What can prevent sulfonamide-induced crystalluria? Take loads of water to flush it out. Also, we can alkalinize the urine because when we are giving sulfonamides, acidic urine is a problem. So if we try to alkalinize the urine, we can prevent it. Amphotericin B. It is another drug causing nephrotoxicity because they bind to cholesterol in renal tubular membranes, causing membrane damage, resulting in electrolyte imbalance and renal impairment. So I'm not asking you to by heart all these things, but you should know what's happening and what will happen when these occurs. These are kind of commonly asked questions. Linezolid, it can cause thrombocytopenia neuropathy, which result in bone marrow suppression, peripheral neuropathy, optic neuropathy. Okay, nerves associated with nerves and also bone marrow suppression. Jarisch hexamer reaction. So this is due to usually occurs in syphilis treatment with penicillin. So in syphilis we have spirochetes. When we are rapidly killing the spirochetes, they can release kind of an endotoxin-like substance. It can trigger the cytokine release, which results in fever, chills, headache, and hypotension. That is Jarisch hexamer reaction, most commonly in syphilis treatment with penicillin. These we are done with that. Now coming to drug resistance, another problem in drug therapy. Where are we? Yeah. So drug resistance, as you know, occurs when the microorganisms survive and continue to grow even if we give antibiotic. That means the microorganisms become resistant to the antimicrobial activity. This can be because of genetic mutations, transfer of resistance genes, or some altered protein expression as well. Main mechanisms. The first one is modification of target site. So, in the bacteria, this is the antibiotic, okay? This is the antibiotic binding site, right? This will come to the antibiotic binding site of the bacteria and stops growth. So what the bacteria is going to do? They will alter the antibiotic binding site. So where can antibiotic bind? No more binding takes place. So the antibiotic can no longer bind effectively. Drug is completely losing its activity. Examples include penicillin resistance, altered penicillin binding proteins, especially Streptococcus pneumoniae. So beta-lactams antibiotics cannot bind properly. MRSA, methicillin resistant Staphylococcus aureus. You'll study what is MRSA. They produce this altered protein binding site, which is resistant to methicillin and many beta-lactam antibiotics. Then macrolide resistance, that is ribosomal binding site mutation. Their site is also altered. They can prevent the erythromycin and azithromycin from binding. I am azithromycin resistant. Azithromycin no more helps in my body. Ampicillin, amoxicillin monotherapy never effect for my body because I'm resistant to the monotherapy. I'm always given amoxicillin, clavulanic acid combination in order to affect my body. I try not to take it, but when I'm having strep throat, all these problems, I will definitely have to take it. Decreased accumulation of drug. That means the concentration in the bacteria becomes too low. The efflux pumps can also be a reason for this because the bacteria can pump antibiotic out of the cell. So they do not reach a therapeutic concentration so that resistance occurs. Another one is decreased uptake. So the reduced permeability. So the antibiotic cannot reach the bacterial, cross the bacterial membrane and produce an effect. For example, gram-negative bacteria, beta-lactam. Okay. Next is enzyme inactivation. The bacteria can produce some enzymes that can destroy or modify antibiotics. These enzymes include beta-lactamases, acetyltransferases, esterases. So what I said, amoxicillin, clavulanic acid. This clavulanic acid is a beta-lactamase
Inhibitors.
enzyme inhibitor.
Inhibitors.
Right. So when amoxicillin is given with clavulanic acid is not going to take part in antimicrobial action. Rather, they inhibit the factor which is inactivating amoxicillin so that amoxicillin can give an effect. Okay, so they break the beta-lactam ring of penicillins and cephalosporins, these beta-lactamases. Hence, the drug becomes inactive. But clavulanic acid will inhibit beta-lactamases. Also, acetyltransferases. They can add an acetyl group to the antibiotic like chloramphenicol or aminoglycoside and thereby inactivate the drug. Esterases. They can hydrolyze the lactone ring of macrolides so that macrolides becomes inactive. So it is not only clavulanic acid. We have sulbactam, tazobactam, and piperazolin, tazobactam, sulbactam, avobactam. All these beta-lactamases inhibitors are there. They all helps. Next, another mechanism of resistance is bypassing metabolic pathway. That means the bacteria develops a different, an alternative metabolic pathway such that the sulfonamide or a particular antibiotic is not gonna affect it. So that the effect is not given. Example, sulfonamide resistance. Bacteria uses external folic acid instead of synthesizing it. Sulfonamides are inhibiting folic acid synthesis in bacteria. But the bacteria finds another way to utilize external folic acid so that you come and bind to me, do whatever you want. I have another ways of affecting your body. Okay. Next is overproduction of target enzymes. That means bacteria produce excess target enzymes. So the antibiotic concentration which is given is not able to inhibit all the enzymes. This is the reason of resistance to trimethoprim. Next is biofilm formation. Bacteria can sometimes form a protective biofilm layer so that antibiotic cannot penetrate this biofilm layer and destroy the bacteria. How clever they are, right? I don't like it. So common organisms include Pseudomonas, Staphylococcus epidermidis. They are usually seen in catheters and prosthetic devices. Another one is genetic transfer of resistance through mutation and plasmid transfer. It is very important because changes in DNA mutation can cause resistance. That's what happened in COVID, even though it is a virus. COVID virus underwent mutation such that they are resistant to vaccines, they are resistant to medications and everything, isn't it? Next is plasmid transfer. Resistance genes are transferred between bacteria. They can occur due to three different methods are there. Just know them. Conjugation, transformation, and transduction. They are the different mechanisms of plasmid transfer between bacteria which can cause resistance. I hope that's everything about the introduction of antibiotics. You need to understand this such that you will understand the coming chapters. Okay. Make sure you go through this. And thank you so much for today.
Thank you, ma'am.
Thank you.